All right, let's get started. Good afternoon. My name is Sam Stewart. I'm a project manager here at the Data and Research Center, and welcome to Friday Office Hours. We have a really informative presentation for you today. I do have a couple quick announcements for some funding opportunities, and then I'm going to introduce our speakers and pass it to them. So I did want to note that the Healthy Americas Foundation is seeking to support up to 20 scholars using the All of Us who are using the All of Us dataset, especially if you're studying chronic disease in communities where there have been limited scientific research. So application deadline is coming up soon next month on November the 3rd. So if you qualify for that, scan the QR code. It will have have the application available and the point of contact. So they are going to select 20 people. Give everyone a quick moment. The next funding opportunity is a funding opportunity with the AIM Ahead program. So AIM Ahead is an All of Us training program for researchers who are working specifically with machine learning models or AI using the All of Us dataset. So if you are interested in joining AIM Ahead, they are selecting participants to receive $8,000 stipend and $2,000 travel allowance for an in-person meeting. So if that's you, please scan the QR code. If you do have questions about AIM Ahead, you can always reach out to support@researchallofus.org. If you'd already applied, it's still open. So it says training program by September 26th, but I just wanted to say if there's anybody who was like, I really want to apply, I wanted to give you guys another opportunity, even though it's October. I'm happy to email the point of contact at AIM Ahead for you if you have questions. There have been people who've joined office. I'm sorry, I didn't know. There are people who have joined office hours before that have been AIM Ahead scholars. They have produced really valuable work. So if you're really interested in getting into ML and AI, that is a group that is for you. All right, I'm going to introduce our speakers, which we're very excited to have today. Mahnaz is the Director of Machine Learning for Health. They're NL4H at the Broad Institute. The Broad Institute works really well with the DRC and in the DRC, so we're excited to have her and her team here today to discuss their methodology using the All of Us research program. She has served as the principal investigator on several NIH directives, including the Direct to Phase 2 SBIR Award for Computer Vision Platform for Non-Invasive Characterization, an initiative to develop fair multimodal AI for disease prediction in All of Us, which is new, and we're very excited about the FAIR framework that she has. I'm going to also introduce Dr. Arash Nargesi, who's a cardiologist and data scientist and informaticist at Mass General Birmingham and Broad Institute. He is working on the AI applications in healthcare with focus on All of Us and other data types as well. And last, Tal Shnitzer is a senior machine learning scientist in the same group, the ML4H team at the Broad Institute. She's earned her PhD in electrical engineering from Technon in Israel, which is very exciting, and focused on manifold learning and genomic techniques. She's also working with this team to develop some methodology that we're going to explore today. And then keep an eye out. Our team will let you know more from this team about a possible workshop in the future. So I'm going to go ahead and pass it all to you all.
Thank you so much, Sam. Thanks for the organizer for inviting us and having us as part of this office hour. As Sam mentioned, my name is Mahnaz Maddah. I'm a director of machine learning for health, and I'm joined by two of my colleagues in my team, Dr. Tal Shnitzer and Arash Nargesi, who will be presenting today. Next slide, please. The focus of our project is disease risk prediction, leveraging the multimodal All of Us data and AI ML modeling. I would put our efforts into three categories. One is the methods and frameworks that we will develop for pre-processing, quality control, and ingestion of the data. And we are aiming to share these with the research community, hopefully to lower the barriers for adoption of the data. And by data nest, I mean specifically the Fitbit data that it is the focus of this presentation. And number two, we will do the multimodal ML model development. And similarly to the methods for pre-processing and quality control of the data, we will also be sharing these methods and techniques with the community. In addition to the code and documentations, we will also planning, as Sam mentioned, a user training workshop early in 2026 to help again with the adoption of the tools and methods and answer any questions that the research community has. Next slide, please. Yeah. As I mentioned, the focus of this presentation is mainly on the Fitbit data and the challenges that we had when we wanted to use the data for AI/ML modeling. So specifically, Tal will be covering the processes that we developed to ingest the data and QC the data to be able to use them for our downstream analysis. And we are hoping that the data set and all the code and documentation will help the research community to adopt the tools and the data, the Fitbit data, much easier later. So next, Tal will be presenting our ingestion quality control processes and also covers actually the Fitbit the fee codes structures that we use for AI/ML modeling. And Arash will be talking about the data trend study that we performed using the ingested data and the clinical value of that study. With that, I'll turn it to Tal.
Thank you, Mahnaz, and thanks, Sam. So hi, everyone. I'm really happy to be here and share our group's work. So I will start with a brief overview of the Fitbit data that we've been working on, and then I'll talk about some of the data ingestion processes and quality control choices that we made and done, as well as a few challenges and lessons that we have learned, and from sleep data specifically as an example. And lastly, I will discuss some of the preliminary ML modeling steps that we've been working on. So first, I want to remark about the presentation that all the examples that we include here are fake and we're not using any actual All of Us participant data, so all is randomly generated. So the Fitbit data on All of Us that we've been using includes the heart rate arrays, which is minute level heart rate throughout the day. It could have some missingness in it. And the steps array, which also has the step count per minute and could also have some missingness. We're also using the sleep data, which is sleep records that have the sleep level, the time and duration. And we're using the activity summary per day that Fitbit also provides. So in order to simplify the use of the data for training deep learning models and ML models in general, our group first focused on ingesting the data and generating pre-processed files and also applied quality control, where Valentina from our group has been the lead of this work. So we decided on creating per participant HDF5 files because this format is more efficient for loading file parts in large data arrays. This file format is hierarchical, and this allows for faster access and loading different file parts more efficiently compared with CSV files. And those advantages allow us to organize the data in a per participant file structure that contains the data from all modalities and all days for that participant, which makes then training deep learning models, for example, easier. So our processing starts from pulling the data from BigQuery, and we're getting the data in the form of CSV files. And then we group the data per person ID and start a Spark cluster to process each such person ID separately and save all the data as HDF5 files. And in this process, we're also applying our quality control functions that I will discuss in the next slide. So what we're saving is three groups of files. For each person ID. So the first group is just the raw data. So for each participant, we have a file of the raw data, the raw heart rate array, steps array, sleep stage info, and daily level stats, just in HDF5 files. The second type of data is the quality controlled and processed data, which includes quality control and some minimal interpolation. And here we're separating the heart rate arrays and step arrays from the sleep data just because it was easier for us, because some of the projects that we've been starting to work on included only heart rate and step arrays. And then when we copy the data into our environment, it was not as big. When we did this pre-processing and pulling of the data, we also applied our quality control functions that we decided on to best fit our projects. So these quality control functions included removing non-feasible values, for example, heart rate values that are less than 30 or higher than 180, and we got to these values by consulting with clinicians and Arash specifically, or steps per minute, which is bigger than 200, for example. And then we also linearly interpolated relatively short segments of missing samples if they are shorter than 90 consecutive samples. And we flag arrays that have missingness if more than 400 samples are missing, which is a threshold that we have decided on as a group. And this is what we see here is on the right is an example of how the to average data over all the step counts look like before and after quality control. So we can see that it changes the data significantly, and we can see much better see the trends here. And specifically for sleep, the sleep data comes as daily as records for sleep data, and we align it similarly to the heart rate and steps array, so it will be midnight to midnight. So all this quality control and data ingestion is organized in notebooks, and we will plan to publish those notebooks with our data ingestion and quality control for the community to use, and it can be used as is or as a template to other decisions, quality control decisions. So for the sleep data, there's a few more processing steps in order to make it more usable for certain deep learning algorithms, for example. So instead of the list of sleep levels and times, we rearrange the sleep data into an array structure. So we organize the different the sleep levels that are listed as different integers and just create this array of sleep data per day. One of the challenges that we encountered when doing this is that some sleep segments, for example, start the day before. So, for example, this light sleep segment could start the day before, and then we split this sleep record into two, so there won't be any artificial gaps in the data. An additional step that we did for the sleep data for certain other types of ML work that we've been working on is organizing the sleep data into a data frame that contains the total minutes of sleep per day per participant, where we separate the is main sleep flag into true or false, where is main sleep in the Fitbit sleep data indicates it's a Fitbit variable that tries to identify whether this sleep segment was part of the main sleep of that day or just an additional sleep, like an afternoon sleep, for example. So to give a few examples for the challenges and lessons that we've learned from processing and quality controlling the data, I will focus a bit more on the sleep data. and give a few examples for what challenges we have encountered. So just to make sure we're on the same page, there's two types of sleep data and the Fitbit data in All of Us. So it's classic levels, so classic sleep levels, which include asleep, restless, or awake, and stages sleep levels, which include light, deep, REM, and wake. And both of those are reported by Fitbit. So when we were looking at a single day, that day could have, for example, different types of sleep recorded in the same day. And for example, a reason for that could be an afternoon nap and the full night sleep, where the reason for either recording classic sleep levels or stages sleep levels for Fitbit is whether someone slept for more than 3 hours or not, and also if the heart rate sensor was recording well the heart rate. So if both of these are true, then the stages are recorded, and if not, then the classic levels are recorded. So typically for shorter periods of sleep, the classic is recorded, but that's not always the case. And some of the challenges that we encountered with the data are, for example, records that are for much longer than a day, for example. So unreasonable length of sleep records, but this is easy to filter for. Another challenge that we encountered is duplicate records. And we think that it will be useful to be aware of that. So some of the records, for example, were completely identical, where the only different for the same participant, where the only difference was the is main sleep, whether it's true or false. Another challenge, which is more challenging a bit, was that sometimes this overlap of records is not an exact duplicate, but rather an overlap between sleep levels and the same night and the same person. Where here, for example, we see a light sleep segment that starts at 10 p.m. and then and lasts for 50 minutes, and then in the middle of it, restless sleep level starts from the classic sleep level types. And in order to deal with those, we also applied further quality control to the sleep data. So the additional quality control steps that we did for the sleep data included filtering out sleep records that have duration of more than 1 day, removing duplicate entries that differ only by is main sleep, and also removing overlap between classic and stages sleep level types, where we gave priority to the stages sleep levels because they are more detailed. And all these quality control steps resulted in losing a total of less than 20 participants. And the last thing that I want to mention about the sleep data challenges is related to sleep modeling. So one of the things that we saw when using this data is that we actually got amazing results for classifying incident disease. But then we looked deeper into the data, and we saw that it's actually caused by some bias. So when looking at the type of sleep levels that Fitbit has, we can see here that in blue are the number of minutes in all of us data that are from the classic sleep type, and in orange it's from the stages sleep level types. And we can see that the data in the beginning was only classic sleep levels, where at around 2017 it started to be from the stages, more from the stages, where classic gradually is reduced but still exists. And then when we instead of classifying the disease characteristics from the modalities, we were actually classifying the date and the Fitbit version and Fitbit algorithm that was used. So we wanted to highlight this as a point to be aware of in the data. Okay, so after applying all the pre-processing and quality control, I just wanted to give an overview of how many participants we are left with in the Fitbit data. So in general, in All of Us, there are more than 600,000 participants, almost 400,000 with EHR and more than 200,000 without EHR. And with Fitbit data, we have around 36,000 participants with any type of Fitbit data with EHR and 22,000 without EHR. And after applying our quality control steps, and filtering steps, which including only days that had less than 400 missing samples for heart rate and step data. And for sleep data, we decided to focus currently on only is main sleep equals true and more than 0 minutes and less than 1,440, which is 1 day, minutes of sleep in a day. And so this resulted in a loss of a few participants, but not a lot. So this is the numbers of participants that we have left and number of days that we have left after for each of the separate modalities. And if we look at the participants that have days with overlap of all the 3 modalities, there are 32,000 participants with EHR that passed our quality control decisions, and around 20,000 without. So then next step before starting to look into machine learning modeling, we needed a class, basically something to classify. So with the help of our collaborators, we decided to focus on FICODEX, which is a recent code structure from 2023 that translates ICD codes to a more clinically focused coding structure. So this is just an example of details of how the code structure looks. So there are 18 categories of, for example, cardiovascular systems, neurological systems, blood immune, and so on. And the first row in light yellow describes the total number of codes in each of those categories. And the darker shade yellow shows the top level category. So this is a hierarchical coding system. And specifically for All of Us, when we looked into the number of participants that have each ICD code that was translated into phi code, in All of Us, those are the numbers. So in blue is the total number of participants that have at least one code from that category. And in purple is the number of participants, the number of codes, sorry, that are the number of top-level codes that the participants in All of Us have. So there is a very good number of participants in All of Us for ML modeling. And this is an example of how the FICODEX actually looks. So this is an example for the cardiovascular code category. So we have top-level categories like rheumatic fever and chronic rheumatic heart disease, hypertension, abnormalities of heartbeat, for example. And then there are subcategories. So for example, for hypertension, we have essential hypertension and secondary hypertension. And for abnormalities of heartbeats, there's tachycardia and bradycardia and so on. And this is just an example of the number of Fitbit participants, of All of Us participants that have Fitbit after quality control in those different, with those different phi codes. So again, there is a very good number of participants for ML modeling in the data. And lastly, we started to work on some preliminary ML modeling steps. And here as well, we've made a few decisions to reduce the amount of bias that we have. So we are working on multimodal modeling. So we are using heart rate, steps, and sleep from the Fitbit data. And we're trying to classify and predict prevalent and incident disease. And one of the decisions that we've made is to currently cap the timeline between the FICO date and the Fitbit data, because the EHR data from All of Us can go back to the 1980s even. And then some of the codes might be irrelevant when we have the Fitbit data from a much later date. Yeah, so and the next steps in our project would be to address additional challenges with the amazing amount of data that we have in All of Us. So there is a lot of data per participant and number of participants, and sometimes the amount of data per participant varies significantly. So it can range anything between a day or a few days to more than 2,000 days. So we are working on developing different methods to deal with those differences for disease classification. Thank you. I'll move it on to Arash.
Perfect. Thanks, Tal. I was just monitoring the chat box. I think most of the questions were answered, but if there are any pressing questions, feel free to speak up. So good afternoon, everyone. It's great to be here with you all. I'm Arash Nargesi, one of the other members of the ML for Health team. And I will show you one example of how these pre-processed data could be used to answer clinical questions. So Tal walked us through a lot of different steps that our group took to clean the data, pre-process that, essentially make it ready for downstream analysis. And of course, we have a lot of ongoing studies about trying to model that. But one of the earlier studies that we chose to use this data to try to answer some of the more relevant clinical questions was this study about describing and investigating the patterns of physical activity and sedentary behavior among US adults in the All of Us research program. So what is the clinical question here? I'm a clinician, so I see people from kind of all walks of life coming to our clinic trying to, consult with us for their cardiovascular disease. And I could have a patient who, let's say, might be a taxi driver, Uber driver. They are working from 8 p.m. in the morning through the morning, and then other patient who might be a math professor and they are working more normal hour, 8 through 5. And a lot of the times when we are trying to advise our patients about their physical activity, we essentially make the same recommendations that, try to have 150 minutes of moderate to vigorous physical activity during the week, without actually recognizing that there are a lot of variations in the population. So there is actually a lot of gaps in understanding those granular patterns of physical activity in the population. And most of this gap is because of the previous studies being limited to either small sample sizes or short durations of follow-up. I think the comparable size samples that you can find with wearable data out there, may have at max a couple of weeks of follow-up. And that actually reflects in the recommendations and the clinical guidelines when essentially the societies and guidelines make universal recommendations for physical activity to everyone. So that's kind of a big problem. And here we are trying to use this wearable data in the All of Us program to inform high resolution evaluation of the physical activity and sedentary behavior, trying to understand both the temporal and the geographic patterns of physical activity across the US, and also understand the associations of these patterns with the human disease. And of course, I guess for the sake of time, I'm just presenting part of our analysis, but there is a lot of different angles that we try to look at this. Next slide, Tal. Yeah, so this is probably a top level kind of a snapshot of some of the temporal results that we got. We chose three primary metrics in this study. One was the step count. I think Tal talked about that. The other two metrics that we chose here were a moderate to vigorous physical activity and the sedentary activity. And there are definitions on how you can calculate those times or classify different stages of physical activity. using both the accelerometer data and the heart rate data. So we kind of used those standard definitions and kind of calculated these metrics for everyone at the minute level. And here you can actually see how this large data set would empower us to look at these temporal patterns of activity and sedentary behavior at all these different time scales. From minute level during the day, we could look at those patterns all the way into multi-year follow-ups. So on the left side, you see the daily patterns at the minute level. Some of the interesting findings here was that, of course, as soon as people wake up, their step count and their MBPA goes up. During those kind of whole hour time stamps, they do a little more. So you see kind of those spikes on the curve. And especially early afternoon, people are a little more sedentary. When you look at the weekly patterns, then you realize that there are not a lot of differences, but those differences are actually significant. People are most active on Saturdays, least active on Sundays. There is not a lot of variation during the different days of a month, but there are very interesting seasonal patterns. People are doing more activity during summer and you're least active in winter. These are the kind of patterns that we anecdotally, maybe intuitively, we recognize in the clinic, but it's amazing to be able to use the wearable data to quantify that. And another very unique aspect of the All of Us wearable data is its multi-year nature of follow-up. So we have thousands and thousands of people that have several months to several years of follow-up. So we can actually look at how these folks are doing across 3 years or 5 years. And of course, a lot of those relationships are impacted, or you can say confounded, by age. But the fact that we can actually quantify how much people are doing at each year is just phenomenal. Next slide, Tal. Yeah, another unique aspect of this data set is just the sheer volume of the data. I think Tal ran through the top level numbers that we have, but we're essentially talking about almost 20 million person days worth of wearable monitoring, with or without EHR. But because we get enough sample size, now we have enough power to look at these patterns across different sociodemographic subgroups. So for example, on the top left, you see all these different patterns across age groups. Folks who are younger, the green line, they are most active at the end of the day. But people who are 65 years of age or older, they get most of their step count early in the morning. There are, of course, significant differences, between males and females, and also across the racial subgroups. Interestingly, the Asian Americans are the most active, especially their activity peaks at the end of the day in late evening. While among African Americans, you see that those average step counts are actually lower than other racial subgroups. There are also very important differences across education, income, and employment subgroups. Here, you appreciate that people who have an advanced degree or they have higher income, they are consistently more physically active than other subgroups. While people who are, let's say, unemployed, they are getting a lot less step counts than people who are retired or employed or students. So just the fact that we could look at all these data and then just have enough sample size to describe these patterns with all these different subgroups is certainly a unique aspect of this data. And all those efforts that we did at the beginning to be able to pre-process this data and clean that would empower studies like this. Next slide. Yeah, there is a lot more into our analysis. I think I just showed you maybe a couple, highlights of that. We looked at these patterns across different US states. We ran a phenome-wide association analysis, in the subgroup that had the EHR data using the FICODX that, Tal mentioned. So we essentially can correlate all these different patterns, step count, MBPA, sedentary times across the different, disease subgroups. And we are hopefully soon be able to submit these data for a publication so we can share those results with the community. Next slide. So just in summary, I think today we shared how we developed the processing and quality control pipeline for the All of Us wearable data. Certainly an asset for the research community. I think as Mahnaz and Tal mentioned, we're going to release this code. So hopefully everyone would be able to get a kickstart and then just try to use this data, the granular minute level data, to be able to answer kind of disease-specific questions in your area of interest. We show essentially some representative use cases of how these data could be used. In this study, that I shared with you, we are describing the temporal and geographic and sociodemographic patterns of physical activity and sedentary behavior across the United States. As Tal mentioned, we are using this data in AI and machine learning modeling for both disease classification and risk prediction. And we are getting very interesting results. Hopefully in future meetings, we can share those results with you all. And using this data, we actually managed to establish multiple collaborations locally at Broad Institute, Mass General Brigham community, trying to leverage this data to answer targeted scientific questions. And of course, our group, I'm sure Mahnaz shares that sentiment with me that we are open to collaboration with other groups. So, yeah. Thank you for your attention. I think I will pass this back to Mahnaz or Sam.
Thank you. This is just I wanted to thank Tal, Arash, and the rest of the team. Also, I wanted to thank NAIR for funding this and all the people involved in the NIH All of Us program that helped us throughout the work and provided us with the support. Thank you so much.
Great. We had a few questions in the chat, so I'm gonna go over a few just so if anyone else met them. Someone was asking about the code, and the team is not ready to share that logic yet, but maybe in the future. Do you guys want to speak to that possibility?
Yes, we definitely, as part of this project, our promise was to share the code, and this is still we are going through the later stages of making sure everything, like review everything and do our own user testing, and then after that we will be releasing the code to the community.
Yeah, that's great. Caroline had a great question. I wonder if the type of physical activity matters. Caroline, do you want to expound on your question for our group today?
Sorry, because I did see, the studies say the differences in physical, physical activity in Asians seem to do more physical activity than other groups. I'm just wondering whether the type of physical activity, perhaps what is called physical activity in other groups may not be how it's captured in a data set. So that's why I'm wondering, because it's interesting results. I would think otherwise.
Maybe I can start answering that, Mahnaz, and you can add if you want to. It's a great question, Caroline. I think we were very thoughtful about this, especially because the vast majority of the previous research is focusing on the step count. And as you mentioned, that doesn't capture the full spectrum of physical activity, especially for people who are doing, let's say, like weightlifting or those activities of a stationary nature. You're on the accelerometer, you are not going to get much, but you are essentially just exercising, and that could be vigorous exercise. So the reason that we included that the second metric, which was that moderate to vigorous physical activity, was to be able to address that limitation. And what goes into that is not just the accelerometer, but also the heart rate. So if you are doing a kind of activity that would accelerate your heart rate, that should be captured through the MVPA. And then there is also that sedentary time, which should kind of complement, when your heart rate is just at your baseline and you are stationary. And, it's a probability calculation. So it's statistical in nature. We can never say for sure that what exactly people were doing at the time. But a lot of these variables are using the same patterns, the heart rate and the accelerometer to classify what kind of activity you are having. I think in kind of the commercial devices, you may actually get some classification of are you rowing or you are running or you are kind of biking or something else. We didn't include that because we just wanted to be able to use a kind of metric that would capture all of them or the vast majority of them. So at least this specific study doesn't go in details of that, and we just simply don't have enough classification in the All of Us data to say what kind of physical activity people are doing. But we try to do our best to be able to kind of include a vast majority of the types of activities people could have. Really good question, though.
Well, thank you very much. I wonder what age groups did you look at? Was that controlled for in your study, the age groups?
You broke off for a second, but I think your question was about what is the control group here?
The age groups. Did you control for age?
Age group. Yeah, adults. So 18 years old or older. Yeah.
Thank you.
Great question. HC, that's the title I had, asked a great question about if you guys were looking at any differences between the people or participants and all of us who provided Fitbit data versus other data types, like with electronic health record data, or provided anything else in surveys to indicate activity.
I can also answer this, Mahnaz, if it is okay. Yeah. So it is also a very important question because I guess the very important angle here is that all of us is very diverse, but it's not necessarily representative. So it's not like enhanced in a way that we are going to go find like a representative sample of the population. So the people who are enrolled in the All of Us are not necessarily kind of the average US population. So that's a very important kind of angle to think about. If people did not have any wearable data, we did not include them here. So this is all the data that is coming from wearable. There is a whole literature around does the questionnaire-based kind of approximation of physical activity correlates with the ground truth? The answer is that not really. So people's, kind of perception of how active they are, from time to time could actually drastically be different than what they are actually doing. I may go to the gym once this week and I may think that, oh, I actually had a very, very, very strong week. I did like exercise 3 times. And it actually turns out that with the important outcomes, the wearable data is a lot more predictive than people self-report. The last thing I want to highlight here is that all of us, the wearable data includes two kind of subgroups. One is essentially a study arm that is called bring your own device, meaning that I could have a personal Fitbit and I just bring it in and I just connect that with the participant kind of portal and I just share my data, which I think is subject to more bias because the type of people who own a wearable might be drastically different than the type of people who may not have a wearable. To mitigate that, all of us actually started running this whole study that is called Wear study, meaning that they are giving a wearable essentially at no cost to especially those underrepresented parts of the population. So, and then you can actually compare how people who own a device are different than people who are given a device. We actually did that analysis in our study. So hopefully when we publish the paper, you can actually look at the differences. There are some differences in there, but the differences are not as much as you may expect. But because of that, you actually can compare, the people who own a device or do not own a device, how different they are.
And to tack onto the WEAR study, those participants were given the device and were prompted to wear it for a year. And so they were prompted to adhere to wearing their device. So that's also going to bring some very interesting results. And I put in the chat just to go over more about the bring your device versus the WEAR study in the wearable device data in the V8 CDR. And so you can learn more about that in that article I just posted. And then we'll take one final question from the chat. Sania asking about occupation type, if you guys were going to possibly provide more granular data on occupation and how that influences the wearable device data that you all are reviewing.
I can also answer that. We didn't go that far because this was a kind of a top level descriptive study, and I think it may just not be the mission of what we do, because like the level that we categorized was employed, like a student, unemployed, retired. That was like the level we went. But that's why we are releasing the code, because there are all these like different angles that people want to look at the details, I guess the social determinants of health, and then people may have different specialties. Like you might be a gastroenterologist, and now you are interested in people who have like pancreatic cancer. How different are than people who are not? I guess like we are probably gonna stay at this level and then just kind of describe kind of like the big patterns and then just move to the AI and ML part of it. But we are hoping that with releasing the code, then the community can actually start answering all those questions without needing to deal with all those kinds of obstacles of pre-processing and cleaning the data. So hopefully this, like our contribution to that mission would be just making it easier for people to take the data and try to answer those questions.
Yeah. So any final questions, feel free to put them in the chat really quickly or come off mute. Okay, if we don't have any other questions, I wanted to highlight one more funding opportunity that I didn't do at the beginning, just to make sure that everyone has an opportunity to see it. And then, yeah, let me share my screen. Okay, there's one more funding opportunity that is coming up on November the 21st with the University of Arizona Banner Health. So they have a fellows program that's going to run for approximately 9 months, so from January to August of next year. And it's a training program. So if you're interested in that, the program manager is Jennifer Smith. You can also scan the QR code and you get a $2,000 stipend. You're going to complete original research projects using the All of Us Researcher Workbench and All of Us dataset. So this may be something you are interested in. I'll give everyone a quick moment. And then, as we mentioned earlier, we will be looking at doing a webinar in the future. So you'll see more information from the All of Us research program related to the webinar with this group study and more information about releasing the code. So keep your eyes peeled for communications on that in moving into 2026. And I just want to thank all three of you all for being here. Clearly, the research community is very excited about this work and look forward to collaborating again.